Hello, welcome to APP virtual lectures. We have two audience viewers tonight, APP to APP and my Catholic doctor. My name is Ledy Ochoa, and I'm going to be doing the Pediatric Dermatology lecture part 2. I hope you guys were able to see my part 1 and you got a lot of information from that. So we're gonna get started. So a little continuation of the part 1. So we're going to continue differentiating different conditions. We're going to see a lot of different things, and we're going to also discuss some treatment for those conditions. We're going to start with our first case, which is going to be head lice. So these are small insects that feed on human blood. They usually niche 7 to 10 days later, and they can stay alive for up to 10 days. One important thing that I always tell my moms, they're not going to be jumping from kid to kid in the classroom, because that's probably what a lot of people think, but they crawl from head to head. And this is how it becomes super contagious. And if one kid gets it in the classroom, they all end up getting it because they are hugging each other, they're playing side by side, or they're sharing things. So this is really, really important. The most common places are going to be the scalp, which is going to be obvious because of the hair, but it could also appear in the neck, on the shoulders, and even sometimes in the eyelashes. So it's really important to check everywhere. I always check. The most important thing when I suspect that a child has lice is I check the back of the head. And what I usually tell them is, I don't check from the front to the back. I always check from the back to the front. And the most important thing is tell them just to flip their hair down, especially if it's a girl. When girls have a lot of hair, especially the little girls, sometimes they don't brush the hair very well. They have huge knots right here. So I always tell them, okay, mom, let me just check the scalp. Let's see how they're doing. And I tell them, put your head down. I start going from the back of the neck all the way to the front. And then you start seeing those little nits just there. And I tell the parents, look, I found one here. I found one there. And the parents are like, oh no, I can't believe they have lights. But I always tell them it's nothing to worry about, that there's treatment. And for my students, if you're in PA school, you probably have to take pharmacology, and you have to know the difference between permethrin 1 and permethrin 2. And this is my little way of remembering it. So I always tell them, and I quiz my medical assistants too, to make sure they always send the right medication. I tell them, think of, for permethrin, it's 1%, and think of like there's a lice in one hair. So that's my way. I always remember to send the right medication. So I always tell them you have to make sure that they don't stay too close to other students in the classroom, not to share any hats or any combs or anything like that. Make sure that at home, if they have brothers and sisters, even the parents, not to sleep with their kids, and just keep everything very clean. The treatment, you want to put it all over the hair. You're going to use a very thin comb, and you want to brush it very well. And sometimes you might have to repeat this 1 week later. The reason why is, like I said, these little mice could stay alive even up to 10 days. So even if you kill some of them, other ones could stay alive. So you just want to make sure that you get rid of all of them, because you don't want to continue treating this little insects. In our office, if we find any of them, we do have a microscope, and we like to see them under the microscope. It's also really good to show the parents what they look like. The kids love to see what they look like. And I want to say thank you to my colleague, Sofia de la Cámara. She's a nurse practitioner, and she gave me this picture. She actually did this. So you could clearly see it right there in the picture, that's a little insect that's not very fun. And they're really hard to get rid of, but there's treatment, nothing to worry about. So head lice. So remember, they crawl, they don't jump, very contagious, and always check the eyelashes as well. Okay, so my next one is going to be scabies. I actually have been seeing a lot of scabies lately, and we see a lot of babies with scabies. I actually had a very interesting case about a month ago. I had a family that came from Mexico. I know now that we have so many people coming through the border, I've been getting a lot of patients, and a lot of them are getting scabies. And this was a little baby. And scabies in babies presents very different. So I'm going to talk about it. in a few minutes. So the most important thing everybody knows is an itchy skin condition. It's caused by Sarcoptes scabiei. It's very contagious and it spreads from contact to contact. So usually it's very common in places where there's a lot of people, like nursing homes, jails, schools, or when there's just a lot of people living in a very small environment. And what they are is that these little mites, they kind of like go under your skin and they lay their eggs, and your body creates this like allergic reaction to these eggs. And the person just becomes super, super itchy and they can't stop scratching at night. So you always want to check on the webs of the hands. You want to check the wrists. You want to check their feet. You want to check the abdomen, their scalp, the back of the knees, the soles in the hands and feet. But in babies, it's very different. It's really not, you're really not going to see it like that. In babies, the two most common places are going to be under the axillas and around the diaper area. And 9 out of 10, I don't, you don't want to say 100%, but 9 out of 10, when I see a little baby that's been itchy for a long time, they have a rash on the axillas around the diaper area, it's most commonly scabies. But in older adults, you're going to see more clinically, like in the arm, like on the finger webs and the toe, between the toes, on the wrists, on the umbilicus areas, but just keep that in mind. And sometimes you even see it like on the scalp. Again, you could do a little skin scraping and you could also see it under the microscope. But the treatment here is going to be permethrin 2%. So remember what I told you? There's a difference between the 1%. I usually do it for the head lice. For my scabies, you're going to do it for permethrin 2%. And what I always tell the parents is that you want to make sure that you clean the house very, very well. You want to vacuum, you want to wash all your sheets and all your clothes with hot water. You want to treat everybody in the household as well. And if there's brothers and sisters, I usually tell them, bring everybody from the house in so I could give them prescriptions, and even the parents, I like to see them. Whoever is at home needs to be treated, because if you only treat one person, that person could contaminate the other person and then you don't get rid of the mite. So cleaning everything with hot water and vacuuming and cleaning the house is super important. But second, you need to make sure that everybody in the household gets treated if you want to get rid of this. Topical steroids, I do it after they do the treatment with the permethrin. So usually what I tell them is that you're going to go pick up your medication at the pharmacy. You're going to apply the medication from the neck down. You're going to sleep with it. And then the next day, you're going to rinse it. And you're going to make sure that you apply the topical steroid, because it usually takes a few days before they start itching and becoming super itchy. So the topical steroid is going to relieve that eagerness to scratch. Sometimes I also might give them a little bit of a topical steroid because they have so many open sores from scratching, and even an antihistamine. So those things are usually really important when I treat my patients that have scabies. And my story about this little girl was that I had a patient come in. They had seen like 2 or 3 pediatricians, and they kept telling her it was something else, something else, something else. And when I came in the room, I asked the parents, how long has she had this condition for? And they told me that ever since they came from Cuba. And I was like, from Cuba? And I asked them, how did you guys come from Cuba? So they told me that they came from Mexico. So right away, I was like, okay, this is definitely scabies. So I told the parents it was scabies, but they told me that nobody else in the house was itchy. So I said, well, that's good, but I'm like really, really sure this is scabies. I'm like, you know what, let's just treat it as scabies and just come back in a week. I want to see the baby for a follow-up, do everything I'm going to tell you, clean everything, and then come back. And that's exactly what they did. They went home, they followed my instructions, they came back a week later, and they were super thankful. They were really, really happy because it was scabies. The little baby was so much better. And then it turned out that other people started to scratch. So then it made me feel good, like, okay, yes. So they all got treated. And at the end, they were happy with the results and they were very thankful. So remember, babies is different. Babies, you want to see them mostly in the axilla and around the diaper area, and sometimes even in the scalp. And I always, when I have a baby or little kids, I always tell the parents too, that even when you treat a scabies condition, it could linger for months. So I continue giving them the antihistamines and the topical steroids because the body kind of gets like this allergic reaction that is really hard to get rid of. So I tell them, we got rid of the scabies, but the body's still trying to fight off that allergic reaction. That's going to take a little bit of time. So even though, yes, the baby's still scratching, I reassured the parent that it's not from the scabies anymore, but from that hypersensitivity that the scabies gave them. And for another case, I did have a parent that she was like, Ledy, are you sure this is still from the scabies? Are you sure? And I said to the mom, I'm pretty positive. I see this all the time. This is exactly what happens. But the mom was very concerned that, you know, we were not missing anything. So I offered her to do a biopsy, and we did. And it came back that it was a reaction to scabies. So then she said, okay, I feel so much better. And I said, perfectly fine, me too. As long as you could sleep at night, I could sleep at night. So everything was really good. So don't ever not think scabies for a little baby, okay? Okay, my next one is onychomycosis, which is fungal infection of the nail. And I do see this a lot in kids. The most important thing that I like to do with nails is doing nail clipping. So a dermatophyte fungi and less common non-dermatophyte mold or yeast. And the reason why is because sometimes when you look at things, they might not come back as what you're thinking. 90% of the time you might be right, but then there could be that 10% where you're like, oh, I was not thinking that, because it could not be fungus. Sometimes it could be mold or it could be yeast. Toenails are most commonly affected with one or all the nails. So you might just see like one toenail, one fingernail, or all the toenails, or one foot, not the other, one arm, one hand, not in a toenail. So especially in my athletes, I see a lot of toe fungus. Nails are often thick and yellow with debris under the nail. And the treatment it's very good, especially for my kids. I always tell parents, I'm very confident that this is going to get so much better if you do the treatment, and not to worry about it. I do like to do a hepatic panel when I start, because a lot of parents get a little nervous about Lamisil, cristofomin, or fluconazole, because they read that it could damage their liver or anything like that. So I always tell them, listen, if you were going to do Lamisil, I would be way more worried. And this is me talking to the parents, because you're an adult and your liver has been going through a lot of damage. But for your son or your daughter, I am not concerned at all, unless they have a problem with the liver. But just because they feel a little concerned about it, I always reassure them. And I said, listen, this is what we could do. Let's do a nail clipping today. Let's wait for the results. And if it's true fungus, then I give them a script to go to the lab and go get a hepatic test. And we're going to check first the liver enzymes to make sure that there's nothing wrong with the liver. If the liver is perfectly fine, then I'm going to send them this medication that is going to be an antifungal, and we're going to treat the nail from the inside and from the outside. And it's going to be so much faster if we do it this way instead of doing something just topical. Because if we go the topical way, it could take months or even years for this to go away. And then we have a little girl here that doesn't want to wear open toe shoes, or a boy that doesn't want anybody to see his toes. And it really starts affecting them. So, and the parents obviously are there because they need my help. So I always like to give my patients options of how to go about the treatment. Sometimes I tell them, let's start first with something that we could just do topically. If you think this is not working, and if you want to go the oral route, I'm perfectly fine. I'm not in a rush. And for the most part, the parents feel very confident when I start telling them about the medication that is very safe, how the liver metabolizes super fast in kids. So the risk of me damaging the liver is very, 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 very small. Now, if I have an adult, that will be completely different. I do not start anybody that's an adult on an oral antifungal unless I definitely have hepatic panel. Sometimes the parents tell me, you know what, I just did my annual with the pediatrician, so I don't think there's anything wrong with the liver. So what I do is that I start them on Grisil or Lamisil or fluconazole, and then 6 weeks later, I repeat the liver enzymes. And then I make them come back to the office. I tell them to take 1 pill every day, which was my number one choice. It is Lamisil. And then the treatment is that I do 6 weeks, and then I have them come back to the office. I review the hepatic enzymes, and then I give them another 6 weeks. So the total treatment is usually 12 weeks. And I also give them something to apply to the nail like cyclopirox. So if the insurance doesn't cover it, we'd have them just crush like 3 Lamisil tablets, and they get a little tincture at the store called fungoid tincture. And I tell them just crush 3 extra pills in here. And then you're gonna just like paint those nails every day. For the girls, I tell them not to apply any nail polish. As the nail starts growing, make sure you always cut it, keep it clean, keep it short. And for the most part, I've never had a problem. All my patients are really happy, and I've seen a lot of toe fungus. And this is a picture of a nail fungus. I don't have an after picture, but this is kind of like what you're looking for. So in this patient, you obviously see that there's only one toe that is affected with the fungus, or the other nails look pretty good. And sometimes it could just be one toe. It doesn't have to be both toes, just one. So one thing too that I like to do with the nail clipping is that if I get the biopsy, sorry, it's not a biopsy, if I get the results back from the nail clipping, it gives me also an idea how to explain the treatment to the parent, because sometimes I've done nail clippings and it's not fungus, it's just a dystrophic nail, or it's a psoriatic nail. So it's a completely different treatment. So why I'm going to put a patient through an antifungal when maybe it's not even fungus? Okay, so that's just, I think it's the right way to do it. Just always verify that it is fungus. Okay, so we're going to go to the next one. Again, this is the toenail. Okay, so we're going to talk about a NEVUS simplex, which is also known as the salmon patch. And this is very, very, very common in children. A lot of babies are born with it. And you will see it mostly like on the forehead. You see like a little red patch right here. Sometimes it's on their nose or like above their lip. And then it's called an angiokiss when you see it on their face. And the other second place is on the back of the head. So sometimes the parents will come in and they tell me, oh, he has like a rash in the back of his neck. And I was telling them, oh, it's not a rash. This is like a birthmark. It will go away, don't worry. And most people call it a stark bite. So a very big difference between a NEVUS simplex or salmon patch is that capillaries on the skin are dilated. Well, there's something else called a port wine stain, which I'm not going to discuss today, but maybe if I do another video, I will. And that's a malformation of the capillaries. So that's obviously sounds a little worse, because it is. It could come with other problems. But this, I always reassure my patients that it's nothing to worry about. It does look red at first, and as the baby starts to grow, it will start fading away. And it could take about a year or 2 for it to go away. And these patches are not associated with any syndromes at all. And there is treatment. So I do have a 5-year-old that she had a really red angiokiss in her forehead. And her parents decided to treat it with pulse-dye laser. And that is the treatment. You treat it with laser, and it's super easy to do. We do it in our office all the time for hemangiomas, for port wine stains, and even for a NEVUS simplex. And every time she cried, or she just always had bangs because she didn't want anybody to see it. And it was becoming a thing with this little girl that she was very self-conscious about it. So for a long time, the parents started the treatment, but then it was really hard to do it for her. So we waited maybe like 2-3 years, and then we went back again, and I started treating her again. So she was one of my favorite patients, and every time she comes to the office now, she has no bangs. Her forehead is perfectly clear. She has no problem, and her parents are super happy. So for some patients that maybe the NEVUS simplex doesn't really go away completely, the treatment of choice is pulse-dye laser. And I always explain to the parents, it's very simple. We do it right in the office. The only thing we do is that we cover the patient's eyes. We all wear goggles, and it's literally like a minute. I just take the laser, beep, 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 and that's it. Some kids cry, some kids don't, but it works very, very well. And I have an example of the injured kiss and the stork bite. So this is a little girl on the left. She has it right on the forehead. She has it actually on her eyes too. And she also has it on the upper lip. And then on the right-hand side, we see it on the back of the neck. This is very common. This is the stork bite. It's not a rash. I always tell the parents, nothing to be concerned about. It's just a birthmark. It will fade away. So a café au lait is a brown macule, so it's completely flat, that appears on the skin. It's most commonly on the trunk and the extremities. They grow proportionally in size as the child grows. So I always tell the parent, this macule, as your child grows, is just going to stretch, because as he grows, the macule is going to stretch with him, especially if it's like in her arm or in the trunk. Not necessarily that the actual patch is going to like spread. If it's spreading, then it's definitely not a café au lait. But there's a condition associated with café au lait. And the magic number, I always tell my students, it's 6. If you count more than 6 café au laits, you always want to refer to genetics. And I do. Even if a patient comes from molluscum and I see more than 6 café au laits, I tell the mom, have you noticed this macules? Have you been to a genetics? Have your pediatrician told you anything about it? And if they have, then I don't worry about it. But if they haven't, I honestly do. I always make sure I give them a referral, and I always make sure I follow up as well, because the most common syndrome with café au lait is neurofibromatosis. There's type 1, there's type 2. But that's one thing I just want to make sure that whenever you see a patient that has a café au lait, they kind of look like this. So obviously this child has multiple café au laits. So this child, we referred to genetics. And sometimes the parents come, they're concerned because the mom will have neurofibromatosis, or the father has it. The kid might not have any café au laits at all, but they're just concerned that maybe in the future they could develop it. So just to give everybody peace of mind, I always make sure that we do. Our next slide is lobular capillary hemangioma, also known as a pyogenic granuloma. They usually grow very, very fast, usually single benign vascular growths, most common in the face, hands, forearms, and fingers. The etiology is unknown and is usually associated with trauma, and they bleed a lot. So most of the time, as soon as I walk into a room and I see a kid with a big red dot, usually a Band-Aid that's full of blood, I'm already like, oh, there has to be a pyogenic granuloma. I always ask what happened, and the parents will usually tell me, oh, it started as this tiny little thing and it's been growing for the past 2-3 weeks. And it's somehow he hit it yesterday and we ended up in the ER and it bled a lot. So that's all very common of a pyogenic granuloma. They start off like a tiny little dot, and it looks like a little like blood growth, just going. And the only way to get rid of it is by cutting it. So you have to biopsy it. And that's usually what I tell my parents. Since they are mostly in the face, one of the biggest thing about the face is scars. So they come in, usually it's like a cheek or around this area is very common. I usually see them mostly like around this area, and they're associated with trauma. So I guess kids just end up hitting themselves somehow around this area. And then this little thing just starts to grow. So I always tell the parents, it is a pyogenic granuloma, it's completely benign, you have nothing to worry about, but the only way to get rid of this is by cutting it off. If we don't cut it, this thing is going to continue to grow. And the second thing I always tell them is that since I'm going to cut it, guess what? I'm probably going to leave a scar, but I'm going to try my best not to leave an ugly scar. And what I do is that I put a lot of lidocaine to make sure that I numb the area very well. And then when I grab it, I make sure that I do it very superficial, because I don't want to leave this kid with a scar for the rest of their life. So biopsy is really the only treatment. If it's in an area that I don't feel comfortable taking, shaving, then I might refer them to a pediatric surgeon. But for the most part, every single pyogenic granuloma that I have encountered, I have removed it myself. And this is exactly what they look like. So As you could see, it's like right here, and it's like this little round ball full of blood. And usually what I also recommend is that when you inject your lidocaine, wait a few minutes. That actually helps too. So when you're cutting it, the blood is, they bleed a lot. So I never forget the first time I ever did a pyogenic granuloma, I was so nervous, so nervous, because this did not stop. No matter how much I tried to cauterize it, it would not stop bleeding. And when I was done doing it, my colleague that was helping me that day, because I asked her to please help me do it, she told me, you know what, next time, just wait a little longer, and that would help with the vessel so that it doesn't bleed as much. So ever since, and that was very good advice from her. That's exactly what I do. I put lidocaine, I wait a few minutes, and then I go and I shave it very superficial so I don't leave any scars. When they come back, we always send it out for biopsy. When they come back, then I start treating, I give the parents options for treatment for the scars. So, I recommend some type of silicone gel or something, sun, make sure that it's still healing very well. But for the most part, they heal very, very good, and you don't have to worry about it. But the treatment, it's biopsy. Okay, so we'll continue. All right, so the second one that's very common in the face is a spider angioma. It's usually a lesion that resembles a spider web. Most common area are the face and arms, may appear as a single or multiple lesions. They usually never bleed. So remember, pyogenic granulomas bleed a lot. The etiology is unknown. It's also associated a little bit with like trauma. Some people say that it could also be associated with like when you, what's the word I'm looking for? When you strain, that's the word, when you strain. And the therapy is electrodesiccation and laser. I usually like laser the best, and I treat all my spider angiomas with lasers. It works 1 or 2 times. You might have to hit it with a laser, but for the most part, they don't leave any scars. The only reason I don't really like to do the electrodesiccation too much is because sometimes you have to go a little deep, and I'm afraid to leave any scars in the face. I'm really cautious with the face, because I know no one would want to have a scar on the face for the rest of their lives, and I don't want to be that person that does that to a kid. So I always tell the parent, laser is really my only option I give them. I don't even tell them about the electrodesiccation. Some people do it, and there's nothing wrong with them, and they feel comfortable with that. I just prefer the laser over it, and then we do have the laser, so it's great. And it's simple. Again, I just tell them we're gonna do one little zap. Usually the area becomes really purple after the laser. So I always tell the patient, if you're gonna do this laser, make sure you don't do it if you have school pictures, if you guys have a trip or you have a wedding or anything like that, because you might have a purple spot for a couple of days and they cannot have any sun exposure. And this is exactly what it looks like. So if you could see it under a dermatoscope, you see like one big red dot, and then it has like little veins. And you could see, actually, that's a really good picture. Again, Sofia de la Cámara, my colleague, she's a nurse practitioner, gave me this picture. And you could see it right there. So sometimes when they're really deep, you might have to do the laser 2 or 3 times, or sometimes you just do it just once. But that's a spider angioma. All right, my next one, it's papular urticaria. And this one's very common, especially in the summer. I see this a lot. It's a chronic or recurrent allergic reaction to insect bites. Most common insects are fleas, mosquitoes, mites, or bed bugs. They usually are firm pink papules. The condition could last months to even years. Clinical diagnosis, but it could be confirmed with a biopsy. And the treatment is very easy. The treatment is very easy. To treat it is really hard. And the reason why is I want to show you this picture, and then I'm going to tell you what I do with my patients. Is that I will have a patient come in just like this. Their arms look like that. Their legs look like that. Their face looks like that. But the most common thing you will see with papular urticaria is that when you check them, usually there's really not many lesions like that, like in their torso. So their torso is usually like clear. But then their their arms and legs are full of scars because they get these lesions that are super, super, super itchy. So obviously, as soon as the one lesion comes out, the patient sits there and digs in there, that opens the skin, and then they end up with all these marks. So it's really hard to treat papillary urticaria because it's like a never-ending cycle, and weeks pass by, months pass by, and the kid's still itching, but you could make it better. And what I always like to explain to the patient, to the parent, is that it doesn't mean, I'm going to go back to the slide, that every little dot in there was a bite. So no, I'm not saying that your kid got bit 100 times. All I'm saying that it took one bite for your kid to get an allergic reaction to this bite, and therefore the body started creating those bumps. So those bumps are created by the allergic reaction from the insect bite. So maybe you guys were outside and your son got one bite. It looks like he got bit 100 times, but that's the allergic reaction. So that's really important, because sometimes when I try to explain it, the parent is like, oh no, we were outside for like 5 minutes. There's no way he got bit all over his body like that. So I always tell them, no, that's not what I'm saying. What I'm saying is that it just took one bite for this to start, and it's going to continue. And I always tell them too, it could take weeks to months for this to go away. So the number one thing you want to do with papillary urticaria is try to figure out what is the trigger. If it's a mosquito, if it's a bed bug, what it could be. Second, you want to prevent this from happening. So if they're outdoors all the time, make sure that they wear long sleeves, mosquito repellent, they cover up, and that they don't like become infected. That's another thing. So what do? The most important thing, we want to make sure that this kid stops scratching, because then we could create an infection with all this open skin. So I always tell them, try to keep their nails short. Again, make sure the areas are covered when you guys go outside. And then I'll give them a topical steroid. Topical steroid, usually for the body, I like triamcinolone or fluticasone. And then I usually give them also mipiracin, which is a topical antibiotic. And I tell them to mix both of them and to apply it to every little lesion, only on the lesion, not like the whole entire arm, but just like one spot by spot. And then I give them an antihistamine, and they have to take that antihistamine every single day. Usually what we do, it's Zyrtec, and this will relieve them. And you will see there's new lesions, and then you'll see there's those old lesions, but eventually they will all go away. And what you have to explain to the parents is that they have to be patient. They have to be very patient, because as much as you want this to go away, there's nothing that we could do to make this go away fast. But we're going to give them the medication, so at least your kids could feel better, and they don't have to suffer so much, because it's very, very itchy. And I've had patients where they're like, Ledy, this is not going away. Again, I biopsy and it comes back as papillary urticaria. And again, I explain to them again, it's going to take time, be patient. I promise this will go away. And it does go away, but it's not fun. So one more time, these are the lesions. They're firm, a lot of open skin from the kid scratching, arms and legs, face, and usually not the torso. Okay. All right. And then this one, Pediatric rosea, is also very common in kids. A common and typically self-limiting eruption that can last 6 to 8 weeks. Starts with a single plaque known as the hair patch, most likely on the trunk, and then it could spread everywhere else. An eruption of multiple oval red scaly plaques follows days 2 weeks later. Most common seen on the trunk and upper extremity, known as the Christmas tree. Mostly asymptomatic, but sometimes it may proceed with a fever, headache, cough, and joint pain. The lesions usually do not appear in the palms, soles, and feet. The exact cause is not known, but is associated with herpes 6 and 7, and the treatment is topical steroids and antihistamines. So I usually have a patient that comes in. The way the rashes appear, it's very interesting, because this is how your mind starts thinking. Like I said, with papillary urticaria, if the kid has rashes like on the arms and on the legs, and not in the torso. And in the face, I'm already thinking, oh, this is papillary urticaria. Now, pityriasis rosea is almost the opposite. You have a rash that usually appears on the torso, and it starts usually with one big, they call it the mother, or we call it in medicine, the hair patch, which we all know the hair patch, but the parents would call it, that's the mother. That has to be the mother because it's so big. So I usually ask, when did this start? I always ask if the kid had a fever, did they feel like they had a cold, do they feel sick? 90% of the time, the kid is perfectly fine. They're not sick. The parents are super worried because this rash came out of nowhere, so now they're here with me, but the kid is perfectly fine. They're not even itchy. Sometimes the rash could be itchy, but for the most part, it's like they didn't have anything in their skin. So history is really important. I always ask, how did this start? So if they tell me, oh, here's the mother, that one big one over there that we know it's the hair patch started, and then other ones started to appear around the torso, the arms, then I start thinking, oh, pityriasis rosea. Pityriasis rosea, you're really not going to see a lot on the legs. You're going to see, again, mostly in the upper extremities and in the torso and in the back. And in the back, when you see a lot, that's what we call the Christmas tree. And that might be like a pants question. I remember that from PA school. So history. Again, if you're not really going to see anything in the palms of the hands or the soles, and really nothing on the face. Well, papillary urticaria, you're definitely going to see a lot of little lesions on the face, arms, and legs, but now with pityriasis rosea. So my treatment is usually, I ask, is the kid itchy? If they tell me yes, I will send a topical steroid and I will send antihistamines. If the mom tells me no, they're perfectly fine, I tell them, then honestly, this rash is going to go away. But it's really important that you explain how long it's going to take, because sometimes they expect this rash to go away within a week, but no, this rash could linger for 6 to 8 weeks. And then what happens is that all these little lesions, once the rash goes away, they could leave either hypopigmentation or hyperpigmentation, which sometimes could take even longer depending on the complexion of the skin. So when you have those little oval patches, you actually could see them and feel them. If they're itchy, I'll send like triamcinolone or fluticasone. And then if they're itchy as well, I'll do like Zyrtec. But if they're not itchy, then I tell the mom why I'm gonna apply something if we don't need it. I'm like, don't worry, just buy some CeraVe over the counter, apply it. If your kid feels bad, then call me back. I'll go send something to the pharmacy. But for the most part, I tell them, don't worry, this is just a virus. It will go away on its own, and it's going to take 6 to 8 weeks to go away. And I have a picture. This is actually my little cousin that got it, and he had a big one, and then little ones started coming around, and he didn't have a fever, he didn't have anything. So we didn't do anything. I just told my cousin, don't worry about it, just let it go. It's gonna be perfectly fine. So that's pretty much it. Those were some common, not super common, but things that you would see that I want you to start thinking like, oh, if it appears here, appears there, like scabies and babies. Remember, scabies and babies is mostly axillas and diaper rash, not like an adult that you're gonna see like in the finger webs and in the toes. So in kids, some things just look a little different, and you don't have to treat every single thing you see. Some things just go away on their own. You just have to give them time, and that's it. So I hope you guys enjoyed my presentation. This is Pediatric Dermatology Part 2. If any of you have any questions, I'll be more happy to answer them. You can always email me if you have any advice or if you need help with anything. I know APP to APP has a link to that you can also contact if you want to get in touch. Okay, I hope you guys enjoyed this. Have a wonderful day. Bye.